I encourage you to write down questions you have so that we can have a panel discussion after all the speakers have spoken. Now, those of you who are looking ahead realize that we have 5 speakers and only 4 chairs up here for speakers. So there's one exception to the rule, and that's Dr. Longo, who will take a few questions after his talk. Because he does have to run, and we're really pleased to have him here. So he's a large part of the reason that I moved here and that we're building this. So Dr. Longo is an old friend, but also the chairman of the neurology department, and really exemplifies why we wanted to do this at Stanford, because it allows us to connect what's going on clinically that you've been hearing about with the incredible basic science engine that is Stanford. So Frank, thanks an awful lot for being here.
Well, thank you, John, and thank you, everybody, for being here. As Department Chair of Neurology, I'd also like to give my welcome to all of you. I'll talk about our efforts to develop therapeutics, a therapy for CMT. So my research group is really devoted for creating therapies for neurologic diseases where we don't have a good therapy. That's what we're devoted to. And we spend a lot of time creating therapies for Alzheimer's disease, but we accidentally tapped into a very powerful approach that looks like it might have some really significant effect on CMT, and we're really excited about that. So I'm going to share some of this with you today. And I'll leave 5 or 10 minutes for questions right after. Okay, so as most of you know, with the various forms of CMT, within the peripheral nerve there, if we take a look inside that nerve, we have the axon fibers, right? And each axon is surrounded by that insulation we call myelin. And in some forms of CMT, the myelin is more effective, it starts to degenerate, and then the nerve doesn't conduct electricity as well. Or in other forms of CMT, the axon starts to degenerate. In both cases, though, one of the big problems is within that axon, which is part of the neuron, the nerve cell, there's what we call a skeleton of proteins that helps that nerve keep its shape and its function. And that skeleton of proteins gets disrupted somehow in CMT, and on almost all the forms of CMT. And once that, what we call cytoskeleton, gets disrupted, and that keeps the shape of the axon just doesn't function as well, and it starts to degenerate. So we're interested in a very powerful treatment that can prevent that degeneration of that framework, that cytoskeleton, within that nerve cell. That's what we're trying to do, and we think if we're successful, we'll have a good treatment for CMT. So, we use mice, and luckily there is a mouse available called the trembler mouse, because it has some shaking to it, that has the same mutation in that PNP22 gene that Carly mentioned that many humans have. And that mutation, I guess I should call it a variation in that gene, when it's in humans, causes one of the most severe forms of CMT. Well, these mice have that identical variation, and they get a severe neuropathy and lose their ability to walk, just like the people. So it gives us an opportunity then to test a treatment in the mice. And it's not practical to go with humans first, so we have to start off with mice. Now, this outlines how we organize our study. These mice are born, and at about 1 month of age, they start getting a trembler. So their nervous system is getting sick from the time of birth. This is happening very early. And we want a mouse version of this disease that's severe. We don't want an easy mouse. So even by a month, it's getting sick. By a month and a half, its gait is abnormal. Mice live for 2 to 3 years, just to give you an idea. So we decided to wait until 3 months. We want this mouse to be significantly affected before we start. That's when we start our treatment. We treat it for 5 months, all the way to 8 months, and then we end the study and we do our nerve analysis, which I'll share with you, and I'll show you a video of our mice. Now, we invented a drug called LM22A-10, and what it does is it goes after a protein target that's located on the surface of nerve cells, on the surface of the Schwann cell myelin, and it triggers a signaling pattern that counteracts that degeneration of that cytoskeleton within the neuron. So it counteracts the degeneration. Now, many of you know in many fields in medicine that we can cure mice of many things. And then when that therapy is brought to people, it's always so disappointing it didn't work. So the medicine has cured mice of cancer, of Alzheimer's, of Parkinson's, and it's just so frustrating. When it gets moved to people, it fails. Why is that? We don't want to repeat that with CMT. One of the reasons we think is because when people do the mouse trials, they make it easy on themselves. They treat the mouse really early before they get sick, so your treatment has a better chance of working. They often test the mild versions of the mouse disease, and they give the mouse tons of drug really frequently, which in the human may end up causing side effects. You're going to have to roll back that dose when you get to people. So we thought we don't want to be yet another failure in people with CMT, so let's make our mouse trial really hard on ourselves. Let's pick one of the mouse versions of CMT that's one of the worst versions of CMT. Let's let the mouse get sick before we start treating it. And partly for practical purposes, we only treat it 3 days per week. Humans could take the drug every day of the week, or maybe twice a day, but we only treat it 3 days a week. Now, admittedly, part of the reason why we chose 3 days a week is because when I ask my laboratory people to come in 7 days a week, including Saturday and Sunday, they're really unhappy. So I said, okay, 3 days per week. And I was okay with that because I thought, I don't want to move something into people unless it's really powerful. And if this is really powerful, I want to see some effect at least if we just treat 3 days per week. So we made this hard on ourselves 3 different ways. It's contrarian in the field. Even some CMT experts didn't have the same view I did. They'd prefer kind of the easier mice, treating a little earlier, et cetera. But I don't want a failure in humans. I want to optimize the chances that something will work in people because it takes a lot of funding to get to people and we don't have very many chances of moving things to people. Okay, so that was the plan, to see if we can affect these mice in any way. So we treated the mice and then we looked inside their nerves. So on the upper left, again, we're just chopping that nerve open and looking inside. We have those axons, those circles, and the dark blue around the light circle, that's the myelin insulation, right? We have the WTs, wild type treated with a vehicle, that's a placebo. Even in mouse trials, we use placebos. Okay, but then when we look at the TR, the trembler mouse, you can see that there aren't as many fibers, they're smaller, the axon diameter is smaller, that myelin insulation's thinner, exactly what happens in people with CMT. And those nerves are just not conducting electricity as well, right? And then we can quantitate all these things. On the lower right, we gave the trembler mouse our drug, we'll call it C10 for short, and it had a small effect in improving the myelin thickness, decreasing the number of axons that weren't sufficiently myelinated, we call those unmyelinated fibers, and just a little bit of a not significant effect on the axon diameter. So small effects here on the big shape of the nerve, but inside the nerve cells there was a dramatic effect. On the upper left, we're looking with an electron microscope now, one of the most powerful types of microscopes in the world, inside that nerve fiber, and those black little dots are what we call are part of the cytoskeleton, right? That keeps that nerve fiber in the correct shape to function properly. In trembler mice, in Charcot-Marie tooth, on the upper right, you just see a higher density of those, what we call neurofilament cytoskeleton. That's an abnormal accumulation of too much of that cytoskeleton protein. That nerve fiber won't work well with that increased abnormal density of too much cytoskeleton protein accumulated. But on the lower right, look what happens when we treat it with our drug. It entirely normalized that abnormality of that cytoskeleton protein. Completely normalized it. You can see the quantitation there, the two red arrows. And I'm not aware of any time this has ever been accomplished in a CMT mouse before. So we were really excited about the nerve inside looked a lot better, virtually completely normalized. But we wanted to see, well, do the mice benefit at all from this? We also looked at some levels of proteins inside the nerve cell. On the left side, there's a protein there that the first red arrow on the left, it's abnormally low in the Charcot-Marie tooth mice, but our drug, C10, brought it back to normal levels. And that's one of the key proteins to look at in CMT. So then we did a Gait analysis, and the Gait and CMT clinical analysis that you're doing in Australia is really impressive, and it sets the stage for being able to test drugs like this. I don't know if our mouse Gait analysis reaches your standards, but we try. Anyway, there are many ways we can give the mice a Gait score, and we're looking at treatments from week 1 all the way to week 21 there on the top. And then we can see the higher the Gait score, the worse the Gait is. And so the trembler mice, the CMT mice in red, have the worst score. You can see it's the highest value. But the trembler mice that got our drug, C10, in the green line, for the first, say, 2/3, all the way up through week 16 there, had improved walking. The walking wasn't normal, but it was significantly improved all the way through week 16. Now, toward the end, as you get to week 21, then their gait started to decline. So this treatment, again, we're only giving it 3 days per week here. And then we have many measures of gait that we can measure in mice. I'll show you the video, but their belly contacts the ground, and when you give the drug, it contacts the ground a smaller amount of the time. Running delay improved, the step swing of the paw improved, and their performance on the ladder climb improved. So we do have a number of ways that we can analyze the gait of a mouse. And all this analysis is done blinded. The people analyzing this, they don't know which mouse got the placebo and which got the drug. It's very important that it's blinded. Okay, so let me see if I can get this video to work here. I don't know if they... Oh, here we go. These are mice walking around. One's treated with placebo and one with drug. There you go, vehicle on the left, drug on the right. So what you'll be looking at here, the one with drug, its belly is on the ground less often than the mouse treated with the vehicle placebo. So look at how often the belly's on the ground, how often that mouse gets itself up off the ground. And you can see the difference. The one treated with drug, it's just getting its belly up off the ground a lot more than the one with the treated with the vehicle placebo. So we analyzed, roughly 15 mice on drug and about 15 mice on the placebo. And then, again, this is all done blinded. The people doing the scoring didn't know which was which. And we found a significant improvement in the walking ability treated with drug. The walking is not normal, but it's much better. So we think that's an exciting start. So what are the next steps? We're currently, and with John's help, trying to plot ways to get more funding, right? That's what people like us are always thinking about how are we going to fund the next bit of work, right? Because what we'd like to do now is continue this project, and this is an exciting start, but let's try different doses of the drug. We want to get to a human clinical trial, and to get to a human trial, you have to know a few things. What's the best dose in a mouse? Right there, we just tried one dose. Let's try 3 different doses. Let's try treating every day of the week, once a day. Possibly we'd get even a more dramatic effect. I mean, I think just that effect alone would be great to offer our CMT patients, but maybe it'd be even better if we treat it every day, right? And then let's look at additional endpoints, but everything we do would be geared toward designing a human trial. That's what it would be all about. And then we would do safety also. And to do a trial to humans, once you're done with mice, you do safety studies in rats and dogs to prove to the FDA that at least in rats and dogs you're safe, and then you get permission to go into people. That's our goal. And then with the CMT consortium, we hope that that would be a great vehicle for us with our colleagues doing this amazing work on how to better assess people with CMT. That'll make the trial more efficient. With the genetic expertise, we'd know, we'd understand who we're enrolling and who we're treating because different genetic versions might respond differently to the drug, so we've got to keep control on that. So everything you heard this morning makes possible doing a trial. We couldn't do a trial without a genetic understanding. We couldn't do a trial without our colleagues who are really experts in assessing function in people. So I'll stop there, but just gives you an idea of where we want this field to go. We want to be able to make people function better. That's the bottom line. So I'll leave time for questions. Thank you.